So we are starting. A very good afternoon and welcome you all to 28th FARO webinar. So we are waiting for the attendees to join. So today's topic is pre-breathing VMAT versus deep inspiration breath hold 3D conformal radiation therapy for left breast cancer, a single institution retrospective dosimetric analysis. This webinar is organized by BSRO, IROS and Aurora. I am Dr. Tanima Adhikari, working as assistant professor in the Department of Radiotherapy, Dhaka Medical College, will be along with us as your moderator today. So at first, we will have our welcome remark. So we have two honorable guests for welcome remark. At first, I would like to invite Dr. Angela Giselvania, treasurer of FARO, for her welcome remark. Dr. Angela, please.
Thank you very much, Dr. Adhikari. Hello, everyone. Welcome to the 28th FARO webinar. I am Dr. Angela Giselvania, currently treasurer of FARO, and it is my pleasure to welcome you all to our today's sessions. We are also honored to have a distinguished group of speakers and panelists with us today. First, I would like to extend a warm welcome to Professor Qazi Mushtaq Hussain, President of Bangladesh Society Radiation Oncology. Hi, Prof. Qazi. It's very nice to meet you again. We are privileged to have his support as of for today's valuable discussions. And also, I'd like to thank to our speaker for the sessions today, Dr. Jobairul Islam, physicist from Bangladesh. We are eager to hear his insights in the dosimetric analysis comparing the two techniques. And also, we are very great to have a group of panelists today. Dr. Biswajit Bhattacharjee from Evercare Hospital in Bangladesh, and also Ms. Ong Sahui, Malaysia, and Dr. Kimiro Hirata from Japan. Hopefully, the sessions will go well and be impactful to improve our clinical practice, gain new perspective and knowledge, and especially for breast cancer patients in our regions. That's all from me. Thank you very much for your participation in this session. Thank you.
Thank you, Dr. Angela. Now, I would like to invite Professor Dr. Qazi Mushtaq Hussain, President of the Bangladesh Society of Radiation Oncologists, for his welcome speech.
Hello. Hello.
Yes, sir.
Good afternoon from Bangladesh. It is nice to meet you all again after a long time. Today's presentation, as you know, on dosimetric planning, it sounds more on physics, but it has great clinical importance, because nowadays the treatment, the outcome of treatment of cancer is very good, and the survival is very high. So people are coming with late complications, especially in case of cardiac complication. It becomes painful for the patients and also for us. So this presentation is trying to say something, how to protect heart during the radiation of left breast cancer, so to prevent complications. I hope you will enjoy it, you will like it. I welcome you to this session, and thank you very much.
Thank you, sir. Before introducing our expert panels and speaker, let's take a group photo. Please, everyone, please turn on your camera, please.
Okay, hello everyone, dear professors and doctors. My name is Kashmal. I'm here to facilitate the session for the group picture. So I will count from 3, and on the count of 1, we'll start. I'll take the picture. Okay, in 3, 2, 1, cheese. Okay, once more. 3, 2, 1, Cheese. Thank you, dear Professor Sandra.
Okay, thank you. So we have three distinguished experts as our panelists. First one is Dr. Biswajit Bhattacharjee. He is Senior Consultant, Radiation and Clinical Oncology Department, Evercare Hospital, Dhaka, Bangladesh. Ms. Ong Sol Hui, she is a Senior Medical Physicist, Cancer and Nuclear Medicine Center, Sunway Medical Center, Malaysia. And Dr. Kimiko Hirata, Radiation Oncologist, Department of Radiation Therapy, Osaka Red Cross Hospital, Osaka, Japan. So, as I already mentioned that our today's topic is pre-breathing VMAT versus deep inspiration breath hold 3D conformal radiation therapy for left breast cancer, a single institution retrospective dosimetric analysis. And it will be presented by Mohammad Jobairul Islam. He is a medical physicist and radiation control officer, Department of Radiation Oncology, Labaid Cancer Hospital and Super Speciality Center, Dhaka, Bangladesh. So before starting our presentation, I would like to inform that there will be a brief question answer session after the presentation. Dear attendee, if you have any question, please write it in the chat box. So now, without further delay, let's start the presentation. I would like to request Mr. Jobair to start his presentation and share his slide. Mr. Jobair, please share your slide. Mr. Jobair. Jobair.
আচ্ছা তুমি শুরু করো হ্যাঁ একটু তনিমা
Hello. হ্যাঁ জি স্যার
হ্যাঁ ওই যে নেট কানেকশন ডিসকানেক্টেড হয়ে গেছিল এখন আসছে
So Mr. Jobair has lost his connection. He's just joining. Please. Sir, Jobair connection পাইছে স্যার
ঢুকতেছে
তাহলে কি স্যার প্যানেলিস্ট কাউকে বলতে বলবো স্যার
প্যানেলিস্ট কি বলবে
এই যে স্যার মায়াঙ্ক তাই বলতেছে স্যার
আচ্ছা তাহলে প্যানেলিস্ট কথা বলতে থাকুক তারা তো দেখছে নাকি
জানি না স্যার আমি লিখছি স্যার যে ওর এক্সপেরিয়েন্স গেছে স্যার
আরে এতক্ষণ তো কি দিচ্ছিল কথা বললাম সব ঠিক ছিল
স্যার কি করবো স্যার
আমারটা তো হটস্পট দিলাম আমারটাও পাচ্ছ না
স্যার আপনারটা দিয়ে ঢুকাই দেন স্যার।
হ্যাঁ আমারটা তো
So Mr. Jobair has lost connection. He is trying to connect. So in the meantime, I think we can
ছিল না
hear experience
One,
from
two, three,
our
four.
panelists.
3, 4.
We can talk to panelists. Our panelist, Ms. Ong Sol-hui, can you share your experience regarding this? Mr. Jobair just lost his connection. We are trying to connect him.
Oh, hi everyone.
Hello.
Greeting from Malaysia. So in our center, mostly we will do
আমারটাই আবার
Please,
তো
sir,
মাইক্রোফোনের
please,
হ্যাঁ।
sir, please mute yourself, sir. Yes, miss.
so in Malaysia, mostly we will prefer patient to do their breath hold technique, and the consultant will decide to use the VMAT technique if they want to cover well with the IMM notes. And mostly in Malaysia, we found out that youngster generally couldn't deliver the breath hold technique compared to elderly. So I'm not sure this is kind of related to the lifestyle of youngster nowadays. And generally, VMAT will give a higher dose to the heart compared to the DIBH technique with 3D CRT. But the con will be for 3D conformer, it will compromise the target, the breast target, as we want to protect the heart using using the MLC to shield the heart. So just wondering whether it's in Japan or in Bangladesh, how is it going?
In Bangladesh, we are as it is a low-income country, so it is a bit expensive to treat with VMAT all the patients. It is quite expensive. So we are trying this new technique to with the deep inspiration breath hold technique to incorporate in the 3D CRT to save the heart in the left breast. No, it is we are a low-income country, so it is a bit. I will say a very expensive procedure in Bangladesh to avail VMAT in all the breast cancer patients.
Then for those who can't perform breath hold, then you will just proceed with 3D CRT?
Yeah, 3D CRT, yes.
Yeah, same go with in Malaysia. So if patient has budget, of course, we will always wanted to upgrade to VMAT, because here most patient can, mostly patients are covered by the insurance.
Okay, thank you, Ms. Wee. So I think Mr. Jobair is back. So please, Jobair, please share your screen. Sorry for the inconvenience, everyone. Sorry. Okay, Jobair, please share your screen.
Sure. I'm sorry for this inconvenience.
Okay. So Mr. Jobair, please start your presentation. Okay.
Thank you, Dr. Modigai, for the kind introductions. Good afternoon, dear esteemed colleagues, distinguished guests, and member of the FARO and BSRO. Also, I'm delighted to see so many of my fellow medical physicists joining us today. I am honored to be here today as a speaker for your official monthly webinar program. I would like to express my sincere gratitude to FARO and BSRO for inviting me to contribute to this important discussion. I also want to extend my deepest appreciation to Professor Dr. Qazi Mushtaq Hussain sir, President of BSRO, for selecting me to represent Bangladesh on this platform. Today, I will be presenting a single retrospective dosimetric analysis comparing free breathing VMAT and deep inspiration breath hold with 3D CRT for left breast cancer treatment. Without further ado, let's begin the presentations. I've done my study at Radiation Oncology Department at Labaid Cancer Hospital and Super Specialist Center in Dhaka, Bangladesh. Breast cancer is the leading cause of cancer mortality among women worldwide. According to the Global data in 2020, 2.3 million new cases were diagnosed globally, surpassing lung cancer as the most common cancer. Shockingly, close to half of all breast cancer patients are diagnosed in Asia. In Bangladesh, we face one of the highest incidence of breast cancer in Asia, with approximately 22.5 cases per 100,000 women annually. Alarmingly, the highest prevalence rate is among young women aged 15 to 44. According to the International Agency for Research on Cancer, over 13,000 women in Bangladesh are diagnosed with breast cancer, and each year more than 700,000 deaths to this disease. Now, I highlight the crucial role of adjuvant radiotherapy in breast cancer treatment. Radiotherapy serves as a powerful counterpoint in the treatment of breast cancer, integrated into the approximately 70% of breast cancer treatment plans. Its ability to enhance the survival and achieve local regional control in patients post-surgery cannot be overstated. This therapy, driven by advanced technologies, minimizes side effects and maximizes treatment effectiveness. Due to radiotherapy, left breast cancer results in higher incidence of ischemic heart disease and premature cardiac mortality. The heart and coronary arteries are located more anteriorly on the left side of the chest wall. During respiration compared to the treatment for the right-sided breast cancer. A research by Darby and his colleagues highlighted this concern. Their study found a concerning linear increases in major coronary events, a 7.4% rise for every gray of mean dose delivered to the heart. And DIBS, a harmonious solution for the left breast cancer therapy. DIBS is a precise method that reduces radiation exposure to the heart during radiation treatment for left breast cancer. As you see, as you can see from this image, without DIBS, your heart is closely to the chest wall, and with DIBS, when the patients take a deep breath hold and hold for a short time period, it creates more space between the heart and the chest wall. It is important to note that not everyone is an ideal candidate for the DIBS techniques. Certain factors such as age, heart presence in the treatment field, breath hold ability, anatomical parameters, and post-planning comparison. To explore the potential benefits of DIBS in our own setting, we conducted a retrospective observational study from February to August 2023. We selected 25 patients in left breast cancer, whereas the 15 was the mastectomy patients and 10 patients of the BCS. And the aim of the study is to compare the dosimetric outcomes of free breathing VMATs and 3D CRT with DIBS in treatment of left breast cancer. And specifically, we're focusing on the three objectives: and target coverage, wear sparing, and treatment efficiency. In inclusion criteria, we added women diagnosis with left breast cancer requiring radiotherapy, and excluded. We did not accept the patients who did not have both a pre-breath scan and DIBS scan completed, and those who had difficulty holding their breath for more than 10 seconds were excluded. And practically implementation DIBS using our Varian RGSC system in our center. The first step is the DIBS is very effective patient coaching. We instruct all patients to breathe in slowly through their nose and emphasizing that they should feel their chest, not from their belly. And this method ensures the lung expand correctly, displace the heart from the chest wall. And patients are trained to perform reproducible deep inspirational breath hold during this radiotherapy. And patient selection is one of the vital part for the DIBS. We selected which patient heart involved greater than 1 centimeter during free breath, and patients must comfortably perform multiple 20 to 25 seconds breath hold. Ideally, we aim for a chest rise of at least 5 millimeters during the breath hold. And another is the laser check to ensure reproducibility, stability, and minimal vertical displacement during breath hold. We mark isocenter for free breathing and DIBS techniques. This helps ensure the consistent and accurate treatment positioning. Now, at first, we began by setting up the patients in the same way as for free breathing simulations. After that, we will set up camera and gating marker block, which should be positioned just below the dyspnea along the midline. And during this scan, we closely monitor the patients to ensure the breath hold position remains constant. And this typically threshold level, upper and lower threshold levels within -2 mm to 3 mm from the reference positions. Patients are planned either 3D tangential field with DIBS or free breathing with VMAT plans. All patients are treated 40 gray in 15 fractions. The plans were generated using Eclipse TPS with AAA algorithm. In 3D CRT techniques, we use 2 opposing tangential for chest wall and single anterior field for supraclavicular, which was the 10 to 15 degree away from the spinal cord. And monoisocentric technique used with 6 MB and 10 MB mixed energy, and we also used field and field techniques. In VMAT, we used 2 partial arcs and beam on gantry rotating clockwise from 145 to 300 degree, and chest wall and supraclavicular were treated using the same arc plans. We compared the dose distribution in pre-breathing, VMAT, and DIBS plan using the DBS, and we also checked 95% of isodose line, hotspot, and cold spot also. In statistical analysis, statistics tests like t-test, chi-square test help us to identify which is significant or not. And all studies done in the SPSS and Excel 2016 versions. And finally, quality assurance, we check for every VMAT patients using the portal dosimetry system before the treatment started. Plan evaluations. We evaluate this plan according to RTOG on 005 protocols, where the more than 95% of the volume receive more than 95% dose, and underdose any part of the PTV shall not exceed 93 of the prescription dose. Overdose to any part of the PTV shall not exceed 115% of the prescription dose, though we did not accept more than 110% in our institute. And volume covered by 107 of isodose line should be less than 2 cc. In OAR, we also check heart mean dose as well as B30 and B5 grade, and for ipsilateral lung B20, B16, B8, and B4. And for LAD, we also check mean dose, and contralateral lung and contralateral breast also checked. Now, dosimetric analysis of the PTV parameters. We used the 5 parameters: B95, Bmax, conformity index, and homogeneity index. If you see this table, here is the first column is the DIBS with 3D set, and second column is the free breath with VMAT. Here is the B95 getting 96.58% volume, and VMAT 99.23% volume. But deviation is not too much high, it's only 2.7%, and Dmax is no significant change in the max dose on 109 and 108. But conformity index in Ideal value is the 1, whereas the closely meets the in VMAT plans 0.99, and conformity index for DIBS is 1.13, which is also acceptable. And homogeneity index value is the nearly 0, is closely meets to 0.07 is the VMAT plans. And dosimetric analysis for the OAR, especially for in a heart, the average heart dose was significantly lower with DIBS, where the 2.67, and compared to the plans in VMAT, which was the 3.9 gray. The mean difference was DIBS and VMAT plans minus 1.23 gray, which is p-value also significantly changed. And another is the lung for V20. In theoretic plants, which gets more lung dose compared to the VMAT plants, but both are within the tolerance limit. But other hand, in VMAT plants receive more low dose volume compared to the 3D CRT. The p-value also significantly changed. In 3D CRT plants receives lower dose to the contralateral lung, contralateral breast, and compared to the VMAT plants, which was also significantly changed. And this is the dose volume histograms. The first of isodose line is the VMAT, and second line is the 3D CRT, which is not too much significantly changed. It's closely meets the RTOG guidelines. If we see this, the lung dose in B20, lung dose is a little bit less compared to the 3D CRT. But if we see the low dose volume, has the 3D CRT is very low compared to the VMAT techniques. And this is the isodose line curves for 3D CRT and VMATs. In 3D compared to the 3D CRT in VMAT plans is superior coverage, but heart, if we see the heart image, the 3D CRT gets low dose in the mean dose in the low. Has the on comparison between the two scan free breath and DIBS. First of all, this is the free breath, which is the maximum heart distance in radiation field more than 2 centimeter, whereas the after DIBS it's less than 1 centimeter, which is 0.9. And particular these patients are heart dose in free breath 5.62, and when it's same patients planned in the DIBS, it gets 3.5 gray. The mean difference is 2.52, the p-value also significant. Our study investigated the effectiveness of DIBS in left breast cancer in radiation therapy. Here is the key findings, some points: dose distribution, target volume coverage, and homogeneity and conformity index. First of all, the target coverage, the both techniques, 3D CRT and VMAT plans, achieve the adequate target coverage. Importantly, there is no significant change between the PTB coverage in 3D CRT and VMAT plans. But in homogeneity and conformity index, VMAT offered better dose distribution with the target area compared to the 3D CRT. In organ at risk, in a heart, if we see the heart dose, the average heart dose was significantly lower with DIBS, whereas that 2.67 gray, and compared to the VMAT plans was the 3.9 gray, and reduction 1.23 gray, whereas the p-value also significant. DIBS ability to minimize the radiation exposure to the heart. For lung dose, as the 3D CRT plans with the DIBS showed the slight increase in the lung dose and for B20 gray. And however, for higher lung dose matrix B8 and B4 is with DIBS lead to the reductions. And for LH dose is not too much difference, not significantly difference observed, but reduced in the DIBS plan. At the mean heart anterior systole distance in free breath is the mean 0.46 centimeter, and in DIBS it's 0.83 centimeter, and mean systole heart distance, this is the CSD, in 0.69 only, due to the mean heart dose is reduced in DIBS. And our study analyzes the relevant significant correlation between the distance between the heart and the anterior chest wall and the mean heart dose in both free breath and DIBS scan. And also one study showed that heart dose significantly reduced when the distance at least 0.5 centimeter. People also significant. As we conclude, I would like to summarize the key findings and implications from our study comparing the DIBS, 3D-CRT, and free breath VMAT. First of all, the feasibility check. The DIBS with 3D-CRT techniques is a feasible alternative to free breath VMAT to developing countries, as the delivering lower dose to critical organs for developing countries is very effective. And another option is the favorable for specific patients. Free breath VMAT is also favorable for elderly with limited life expectancy, and DIBS not mandatory for all patients who is the unable to or ineligible the breath hold. And in organized pairing, DIBS 3D-CRT reduce the radiation exposure to heart, lungs, and breast compared to the free breath. Patient selection is very careful area. Careful patient selection is crucial for optimal resource allocation. DIBS may not necessary for all patients, especially if the dosimetric benefits is minimal. As we conclude this session, I would like to leave you with a takeaway message. The underscore the importance of cost-effective radiotherapy options, especially for resource limited settings. Why DIBS 3D-CRT makes a difference? Because DIBS 3D-CRT emerges cost-effective radiotherapy options for resource limited setting, particularly in developing countries, while VMAT has some dosimetric advantage, but 3D-CRT DIBS is closely matched to the RTOG guidelines. And our research demonstrations already showed that DIBS 3D-CRT delivers target radiations and achieves similar outcomes to VMAT, while the minimizing the exposure to healthy tissue. I acknowledge to our colleagues, Dr. MD Abdul Mannan, Junior Consultant, and Dr. Ahmed Al Mamun Suit, who controlled these patients and evaluated these patient evaluations. And also dedicated sincere thanks to radiation therapist of our center. Thank you.
Thank you, Mr. Jobair, for your wonderful presentation. I think it is an excellent topic for low-income countries like us. So now it is the time for the question and answer session. So we have some question in our chat box or question answer. I would like to read that question, and Mr. Jobair, you please answer this. So there is a question for from Meher Jabin. What options are available for patients who can hold their breath for a shorter duration? So, Mr. Jobair.
Thank you. It's a very interesting questions, especially before the 3D-CRT with the DIBS techniques. We counseling the patients and showing the previous any DIBS techniques portfolio from our desktop, and counseling the patient breath hold from nose, and then after that we getting a scan, and then if he hold minimum 15 seconds, then we accept, and for want to suggest 2 or 3 times daily. After 2 or 3 days later, then we complete the DIBS scan.
Okay, thank you. So another question is from Dr. Shahid Motin. That is, does DIBS increase treatment time compared to VMAT, and how does this impact patients and workflow?
Oh, that's very important questions. DIBS can increase the treatment time due to the needs of the repeated breath hold and careful monitor the patient's positions. This can impact workflow, requiring more time per patients, potentially reducing the number of the patients that can be treated in a day. That's why it's not big problem in the any department, I think.
So another question is from Mr. Rajan Kumar, and his question is that before the treatment of carcinoma left breast cancer, we do a CT scan. Can you please tell me how much minimum air patient can inhale that we can perform treatment smoothly?
So, sorry.
So there is a question that before the treatment of carcinoma left breast, we do a CT scan.
Yeah.
So can you please tell me how much minimum air patient can inhale that we can perform treatment smoothly? How
Okay.
much patient should inhale?
Breath hold.
Yeah.
It is 20 to 25 seconds is appropriate for every DABS patients.
Okay. So there is another question from Mohammad Alamin, that if all facilities available, what are the parameters we should consider before choosing in between DIBH with 3D CRT versus free breathing VMAT? So if everything,
At first, we will
yeah.
At first, check the patient's parameter as maximum heart distance in the CTMS. Then patient's central heart distance also check. Patient age, BMI, and who is how much heart involved in the radiation field.
Okay. So another attendee wants to know that how do you find the compliance of the patient to DIBH technique? So how what patient's compliance to the DIBH?
During DIBS, definitely we scan the free breath scan. Then we'll check the heart and lung positions. If the heart is very closely to the chest wall, then we'll tell to the patients for DIBS.
Okay, thank you. So another question is there any other specific criteria in choosing patients for DIBH other than the age factor and heart and lung disease? So I think you have
already
you have answered this question. So there is another question. You have already answered this question also, that eligible criteria for DIBH. So another is for developing countries, what would be the other option? Who can adopted the resource limited setting in context of the left-sided breast cancer radiotherapy? Now, what other option can be adopted in low-income countries, developing countries, for left-sided breast cancer?
For developing countries, and or resource limited sense, if available the DIBS, we may go to the DIBS in 3D CRT patients, because the patients gets more low volume dose, which the in affected more than double times in the VMAT plans compared to the 3D CRT.
So another question is, what if the patient couldn't comply to DIBH? What is your next option?
Sorry.
So if the patient couldn't comply to the DIBH, that is deep inspiration breath hold, what will be the next option?
If it's not eligible for this DIBS, then we'll if the RNI, the patient's left breast is involved the RNI, a compressive RNI, we instruct to the higher techniques IMRT or PVAT. And if it is only left breast, then we may also take the 3D CRT techniques.
So what another question is, Mr. John Mark Carago, what if during the treatment can no longer perform DIBH with the same quality with the CT simulation? What treatment modification do we do in this situation? That is
especially we take 2 or 3 times if the patient is stable, and we monitor is the same line for the minimum threshold level, minus 2 mm to 3 mm plus 3 mm. When it's stable, we'll take the DIBS scans for plan purpose.
Okay. So there is another question in the chat box. Could you discuss the challenges and limitation of implementation of DIVH in a clinical setting?
That's very interesting questions. Actually, challenges ensuring the patient compliance with DIVS, maintaining the consistent breath hold position, manage and increase the complexity of the treatment planning also delivered. And limitation is not all patients are suitable for DIVS due to the factor like age, inability to hold the breath, existing lung or breath, heart disease. This is also need for the additional training equipment, which is can be resource intensive.
Okay, I think we have taken all the questions. If you have any other question, you can also raise hand so we can take the questions. So if there is no other question, I think we can go to our panel of experts. So now I would like to invite our panel of experts, Mr. Dr. Biswajit Bhattacharjee, Senior Consultant, Radiation and Clinical Oncology, Evercare Hospital, to share his experience and say something about this topic.
Thank you, Jobair, for your nice presentation. And I am very much expressing my gratitude to FARO and BSRO to give me the chance to become a panelist in this session. He delivered all the things very nicely. And I think to treat the left-sided breast cancer by radiotherapy, it's a big challenge to control the dose in the heart. No doubt about it. So we all agree for that. And he nicely presented the role of RT for the breast cancer. And he has shown the importance of patient selection. Yes, patient selection is very much important. The one thing I just want to say that we cannot say that DIVH or VMAT or 3D CRT is good, bad, or something like that. So it depends on patients to patients. So the ways that we have to see their anatomical structures, their chest conformity, and the distance between the heart, and because it differs from man to man. So for some patients, maybe we may need to go for the DIVH that is the best for her. In some patients, maybe 3D CRT is the best for her. So the patient selection is a very important thing. And then he explained the patient education. Yes, patient education is a very crucial thing, because if patient doesn't understand what's the role for her, and then they cannot maintain it. So if they cannot maintain it, so we cannot maintain our DIVH treatment. So, and he also explained the benefits of DIVH, and we all agree with that. And in his exclusion criteria, he mentioned that he excluded the patients having lung and heart disease. So my question is, if a patient has a left-sided breast cancer and having lung and heart disease, so then shall I straight say that we cannot do DIVH? So I think we have to evaluate the lung and heart, how much lung is affected, whether its tidal volume is okay or not, and we can do a echo and see what is the heart's condition. Then we can decide, yes, she is entitled for the DIVH, or she is not entitled for the DIVH. So for the research purpose, it is okay. But for clinical part, definitely you have to evaluate the lung and heart condition. Then in conclusion, he mentioned the take-home message like that in developing country. And I have seen some questions that if a center doesn't have that RPM or ABC, then what would be the options for them? I think we all know there is a paper is published in the Advances in Breast Cancer Research in July 2021. One of our colleagues from Bangladesh, Dr. Arifur Rahman, he published an article, and he has done a study on 60 patients in our National Cancer Institute. And he used a custom-made that breath hold indicator scale. And that is a very excellent method. So I think for the developing country, in almost most of the centers, we don't have the RPM or ABC. So we can do some kind of head-to-head trial that we are treating patient using that RPM or AVC, and we are treating with this breath holding that indicator scale. So then we can recommend for our patients or our fellow colleagues, yes, if we don't have that RPM or AVC, we can use this breath hold indicator scale. And I think in the almost all the coronary he touched very nicely. And as a clinician, definitely I would like to lessen the dose that our heart will have. That is a very burning question. And for that reason, we have to select the patient very cautiously, and we should not think that all patients is eligible for the DIBH. And accordingly, if we place it, then I think we can provide our best service to our patients who are having the left-sided breast radiation and avoiding the heart. Thank you so much.
Thank you, sir. Thank you, sir, for your excellent remarks, sir. Now I would like to invite Ms. Ong Saw V, Senior Medical Physicist, to say something regarding this presentation.
Hi, thank you for inviting me. And first of all, this is a very good presentation putting by Mr. Jobairul. And as a physicist, I feel like we want it all. We just want the best for patients. We always prioritize, we want to use the DIBH and VMAT to produce a better coverage, but in certain circumstances, just is not possible, whether the patient is not fit for DIBH technique or patient has some financial constraint. I guess the limit and the challenges from the hospital side will be how we guide patient and how we train patient beforehand to produce a reproducible breath deep inspirations, where we need to put more resources, time before the patient get selected for the DIBH. And also, I understand that most of some of center doesn't have the guided indicator for the patient. It doesn't have the system where the breath hold indicator manual system is one of the options where I have seen it in Taiwan. It's called RESCON system. It just measure, it put a pad on the patient chest, and then when the patient breathes, that the indicator will move. So from the hospital, from the staff side, we just have to closely monitor the indicator where when the patient release the breath, and then the radiation therapist must immediately stop the treatment. So this is one of the alternative if you don't have like advanced system like a surface guided system or even VMAT RPM. And also breath hold technique require a lot of training on the patients, because most of the time from the patient side is they don't know how much they need to take a breath, and then how much is enough for them. So it will be good that from the hospital side just provide an indicator to the patient to see. And I think that's all I can share. Thank you.
Okay, thank you, Ms. V, for your valuable comments. Now I like to invite Dr. Kimiko Hirata, radiation oncologist from Japan, to share his experience and say something regarding this topic.
Hey, thank you.
Hello.
Hello, my name is Kimiko Hirata from Osaka Red Cross Hospital. I'm a radiation oncologist, and I listened to the lecture and prior discussion with great interest. I think that DIBH is very effective and easy way to reduce the dose to the heart. So in Japan, DIBH has become quite popular recently. But However, some facilities do not perform DIBH at all, or only a few facilities perform DIBH on all left-sided breast cancer. Maybe I think this may be due to a lack of equipment for managing respiratory movement, and also longer treatment time reduce the availability of radiation therapy. So as you discussed before, I think that some criteria is required for using DIBH. And as a radiation oncologist, I'm struggling in daily clinical practice to decide some criteria for using DIBH. And may I ask a little question to Dr. Islam about the VMAT?
Sure.
What did you think about the respiratory motion of the chest wall or breast in free breathing VMAT? In my experience, the respiratory motion is usually 2 to 3 millimeter, and this is very small amount. Do you think we can limit the small amount of movement?
Okay. In that case, we use the virtual gloss in VMAT techniques, where the 2 centimeters from the body, and the lip did not come too close to the body. That shows the
I think we lost him again.
I think we
Yeah,
lost.
in our
this is the
center we
lower
use.
volume. This is the main problem. The before and
I
hello.
think
Are-
so. Jobair, are you there?
hello, are you hearing me?
Now
Yes.
we can hear you. Now we can hear you. Say.
We can see him.
Techniques we used
Cannot hear.
virtual plus.
Now you can speak now. Now we can see you and hear you.
Okay.
So I think there is a bit connection problem.
When you will plus,
I think you should turn off your camera and then talk. Okay, now talk.
okay. Are you hearing?
Yeah.
Okay. When you use the VMAT techniques in left-sided breast cancer or right-sided breast cancer, we always use the virtual plus for the from the body in 2 millimeter due to the air gap in VMAT. There is no without virtual plus. We did not stop the MLC in the closely the body. That's why you use the virtual bullous, where is the 2 centimeter air gap. And in free breathing, VMAT is okay, but one issue is the lung dose for the B4 gray and the B8 gray. The maximum times when we use the P4, it's gets more than 55%, which is the RTOG guideline. In RTOG 1005, it's recommended B4 in less than the 55% volume, but it's quite tough to manage within this tolerance, and that's the main issue. And it's always depends on the clinical decision. He or she would accept or not accept it. If we use the DIBS, then in theory we may omit these options. And we always we know everyone in VMAT or IMRTs the low dose is more.
Sorry, can I just confirm again your margin? Just now you mentioned is 2 cm or 5.
This margin, that means virtual bolus for the VMAT techniques. So in free breath techniques or the VMAT techniques, free breath or DABS, in that when you use the 360, we always the leave 2 centimeters away from the body. That's why the when the deep respiration, inspiration or inhale or exhale, the body always the up and down. We may solve the issue in the 3D techniques, but it's quite difficult the VMAT techniques if we do not check the everyday CBCT. If IGRT is available, then it's okay without virtual bolus, but without IGRT, I think virtual bolus maybe help. Virtual bolus, that means just air gap, nothing else.
Okay.
Thank you.
So Dr. So now Dr. Kimiko has, will you say anything more?
No,
Okay.
no comments. Thank you.
Okay, thank you. So thank you, Dr. Kimito, for your nice comments. So we have come to an end of today's webinar. On behalf of BSRO, I would like to thank all the panelists and our speaker, and especially FARO, to give us the opportunity to participate in this webinar. With this, I am concluding today's webinar. Thank you all for patient sharing.
Okay. Thank you so
Bye.
much.
Thank you.
Bye.
Bye.
Bye, everybody.
Thank you.
Thanks.
Bye.
Bye, everybody.
Bye.
Bye.
Angela,
Hi, Prof. Qazi. How are
yeah.
you?
Are you coming to Malaysia?
Yes, I guess so. You will too?
Hope
Okay, see you
to meet
there.
you again. Yeah.
Yeah, till
Okay.
we
Thank
meet
you.
again. Bye-bye.
So,
Thank you.
how was
Wonderful
it?
session today.
Is it good?
Good. Thank
Yeah.
you so
Thank you.
much.
Thank you.
Bye-bye.
Bye.
Bye.
Bye, everyone. Thank
Bye,
you.
everyone. Bye. Thank you. Thank you. Thank you, Mayang.
Down, Mang. ঠিক আছে নাও হ্যাঁ